Welcome to 7 Pillars of Life. In this training, we're going to walk through case conceptualization, what it is, why it matters, and how to create one that leads to strong treatment planning. I want you to feel confident after this video, not overwhelmed. So pause when you need to, take notes, and come back as needed. Case conceptualization is your clinical explanation of what's happening beneath the surface. A case summary tells me what happened. A case conceptualization tells me why it happened, what's maintaining it, and what we should do next. It's how we move from describing symptoms to understanding the story. Conceptualization matters because it guides everything, your goals, your interventions, and how you track progress. It keeps you from doing random therapy that feels like a checklist. It also reduces therapist biases, helps supervision stay clear, and improves continuity of care if another clinician ever needs to step in. Symptoms are important, but they're not the full story. Your job is to look for patterns, what repeats over time, what triggers decline, and what keeps the cycle going. You are also paying attention to core beliefs, coping strategies, and the client's relationships and environments. Use the biopsychosocial model so you don't miss key factors. Think biological, sleep, health, medication, genetics. Psychological, trauma history, thoughts, coping, emotional regulation. And social, relationships, work stress, finances, housing, and culture. Then connect them all. The best conceptualizations show how these layers interact, so they all must be looked at. That is what a good biopsychosocial does. Cultural humility is essential here. Cultural shapes how clients express distress, how they view mental health, and what support looks like. Include family values, spirituality, community expectations, and experiences of discrimination or chronic stress when relevant. And be mindful, don't over pathologize behavior that may be culturally normal. Make sure you're looking for that when you're doing your biopsychosocial and during your sessions. A trauma-informed lens shifts the question from what's wrong with you to what happened to you. A lot of behaviors that look dysfunctional today were once survival strategies. So we identify adaptation, watch for nervous system patterns, and we use language that protects dignity, no blame, no shame. Strengths are not fluff. Strengths are clinical data. Resilience, motivation, values, support systems, those are protective factors that can keep clients stable and help treatment work. Ask yourself, what has helped before? And what can we build on now? Here's a key distinction. A problem list is what you see. A formulation is what you understand. For example, anxiety might actually be an avoidance cycle, fear of rejection, and chronic work stress all reinforcing each other. Your formulation is what justifies your treatment approach. A strong conceptualization includes the presenting concerns, the onset and course, and the 4 Ps. Predisposing factors, what sets the foundation. Precipitating factors, what triggered the current issues. Perpetrating factors, what maintains the problem today. Protective factors, what buffers and supports the client. Then end with a clear hypothesis, what maintains symptoms and what will help. When you're stuck, use mapping questions. What are the top 1 to 3 problems we are treating right now? What stressors increase symptoms? What beliefs keep showing up? These are important mapping questions while you're trying to conceptualize your case. What behaviors are maintaining the cycle, and what strengths can we build on? This keeps your conceptualization focused and clinical. Common mistakes. Let's normalize the learning curve. Common intern mistakes, including listing symptoms with no interpretation, ignoring context, and missing strengths. Another big one is choosing interventions that don't connect back to your formulation. Always ask, does this intervention match my hypothesis about what's maintaining the problem? Here's a quick example of an anxiety cycle. A trigger happens, like conflict or uncertainty. The thought shows up, I'm going to fail. The feeling follows, panic or shame. The behavior, avoidance or reassurance seeking. The client feels relief short term, but the anxiety gets stronger long term. This is what you're looking for when you're conceptualizing. Now we turn the conceptualization into goals. Choose 2 or 3 measurable goals connected to the maintaining cycle. Goals should align with the client's values and readiness. Use SMART language, specific and trackable. For example, reducing avoidance by using graded exposure. Please make sure you look up and remember what SMART language is. Your intervention should match your formulation. CBT helps with thought distortion and behavioral experiments. ACT supports value-based action and acceptance skills. DBT builds emotion regulation and distress tolerance. Trauma approaches focus on safety, stabilization, and processing when appropriate. Whatever you choose, justify why it fits this client. You must be able to justify the choice that you're making in your formulation to justify with that particular client. Documentation should be clear, respectful, and clinically grounded. Use non-stigmatizing language. Separate facts from clinical impressions. Tie your impressions to assessment data. That's where doing assessments that are available is important. Protect confidentiality, avoid unnecessary identifiers, and write as if another clinician will need to understand your reasoning. For your assignment, you will submit a 1 to 2 page case conceptualization for one current client along with a treatment plan. Include the presenting concerns, biopsychosocial factors, the 4 P's, and strengths. Then write your clinical hypothesis and a preliminary treatment direction, which is the treatment plan. Then you're going to submit it to your assigned folder by the due date. Before you submit, what patterns do you notice over time? What beliefs may be driving behavior? What is maintaining the problem today? What strengths can be leveraged in treatment? And what questions do you still have that you want to bring to supervision? Conceptualization is a skill that improves with practice. Please remember that. It's also a living document, meaning it will evolve as you learn more about the client. Bring your questions to supervision and don't be afraid to think out loud. You're learning how to think like a clinician, not just fill out paperwork. Thank you for completing this training. Upload your assignment and come prepared to discuss your case conceptualization in supervision or when we assign it.